Thank you. Sorry.
Yeah.
Okay. Perfect. Okay. Okay. Let's share my screen. All right. Can everybody see my little slideshow?
Yes.
Okay, perfect. All right. So welcome everybody again to the monthly lab meeting. Just to catch everybody up on what's been going on, we have had a few abstracts submitted to both the CPDD and ASAM conference, with the newest one highlighted with Dr. Madison Marcus. She submitted a pharmacological abstract regarding a fentanyl primed reinstatement of fentanyl seeking, which also got accepted. And then we had a few new published manuscripts. Congrats to Michelle Aglovich and Chloe Lessard. Both of their manuscripts got accepted for publication through PLAW's Mental Health and Journal of Addiction Medicine. Yay. And then we also have a few manuscripts in review currently. And then if you aren't already following, please follow us on Twitter and X, whichever you call it. I still call it Twitter. And then here's our YouTube channel. So if ever you miss a meeting or anything like that, we always post the recording on our YouTube channel so you can stay up to date with all of the research that we're doing. And we also have our LinkedIn. Here we post a lot of like our recent publications and highlight some student work. So if you aren't following us on that, feel free. And then our Instagram page. We have quite a bit more followers now. I haven't updated this slide yet, but it is quite a bit more active. So go ahead and follow us on this as well if you haven't already. And then our lead RAs in the lab who are heading all of the media is Arjun and Ira. They've been such a tremendous help with all of that. And then as for studies, currently going on within the lab, we have CBTIO, which is adapting cognitive behavioral therapy for insomnia, specifically with people with OUD or opioid use disorder. We just finished up the planning phase, so now we're pre-testing and we've recruited a couple participants so far, which is really exciting. Michelle, one of our senior lab members, is heading this study, but this is using primarily data from SORT and registry. Like previously mentioned, we have Project SORT. Recruitment for this study is complete, but we are continuing to do chart reviews. This particular project is investigating sleep and OUD. And then for the registry study, we recently completed recruitment, but chart reviews are still ongoing. This study particularly is tracking clinical outcomes of pregnant and postpartum patients who seek addiction treatment with our OB Motivate clinic. And then we also have Project Castle. This project is primarily focused on developing a computerized intervention program that educates pre and medical professionals on substance use disorder stigma. Right now, we are in the study pre-testing phase, and Dr. Madison Marcus and myself are the lead RAs currently working on the project with some of the other lab members. And then we also have the educational studies. So far, the clinical research curriculum study is ongoing with a manuscript by Catherine Henderson is in prep using the data from a couple years ago, which is really exciting. And then here's some of our pending research support. And then our next lab meeting so far is scheduled for April 28th. I have not sent invite yet for the calendar, but you will see that shortly, probably next week. But for those of you who are new to the lab and are wanting to volunteer some time or interested in learning more about some of the projects that we just discussed, just email me to schedule a 30-minute meeting with Dr. Martin after we hop off of the meeting. We can get that scheduled for you. Oops, no, but that is it on my end. Rabia, you're ready. You can go ahead and start sharing.
Thank you, Amber, for all the lovely updates. I'm going to start my.
And Rabia, make sure you give like an intro of where you're at, where you come from.
Okay.
Everyone who doesn't know you.
Oh,
Oh
that'll
yes,
that'll be good.
thank you for reminding. I totally forgot that part, so thank you.
Yeah, we do have a bunch of new people on today, so that'll be good. Good idea.
Yes. Oh, sorry about that. Are you able to see the screen?
Yes, looks good.
Okay. So, this is me, Dr. Rabia Hanif. I come from Pakistan, and I was a postdoctoral scholar at Ivy Lab. I'm still a postdoctoral scholar until 31st July, and by profession, I'm a clinical psychologist. Back home, I was working as a head of the Department of Psychology, and here. At Ivy Lab, my mentor, Dr. Caitlin Martin, I worked with her, and this project that I'm going to share for now. So, the topic of our project was Understanding Insomnia and Aggression, Gender Specific Patterns in Opioid Use Disorder Treatment. Three basic variables of our study were insomnia, aggression, and gender. So, insomnia is a prevalent issue among individuals with opioid use disorder receiving buprenorphine, according to the latest researches that we had from 2021, and even Ellis in 2022, and White et al. They did mention that insomnia might exacerbate existing psychological impact, and also that can hinder our treatment outcomes. So, with reference to aggression, it was never studied among the population or within the population of opioid use disorders, but in general population, according to the researches by Zhang et al. In 2023 and Kempis in 2012, they did found out that by treating sleep disturbances, there was a reduction in aggressive behaviors and problematic behaviors altogether. With reference to gender, there have been mixed feelings when it comes to insomnia, but it was never studied in relation to insomnia and aggression among OUD population. Moving further. Um, so I have included bit introduction, more of a psychological side as well. So for those who do not have any psychological background, so they can have an understanding how it is being studied in relation to insomnia is being studied in relation to aggression. So general sleep aggression model proposes that disturbed sleep, particularly insomnia, plays a crucial role in increasing aggressive tendencies by impairing cognitive functioning, emotional regulation, and impulse control. This model actually derived from general aggression model that was given by Anderson and Bhushan in 2002, which integrates three different fields of psychology, or you can say three different fields of research, which include sleep research, neuropsychology, and stress physiology. According to this general aggression model, it proposes a hypothesis which says poor sleep, particularly insomnia, contributes to aggression by impairing cognitive and emotional control, according to the research by Kempis in 2012. There are in total three pathways which can produce aggression among people who are having insomnia. So, according to these pathways, number one pathway is cognitive dysfunction pathway. So, what happens is that sleep deprivation impairs executive functioning, which reduces problem solving abilities and ultimately impulse control problem. So, individual experiencing insomnia with frustration tolerance leading to aggressive tendencies, according to the research by Allen in 2018. In a second pathway, which is emotional dysregulation, according to that, a negative effect So insomnia increases the negative mood, irritability, and anger and frustration, which ultimately leads towards aggression. And then the third pathway, which is physiological or hyperarousal pathway, which is actually related to the hormonal release. So chronic sleep disturbances results in heightened HPA axis activation, leading to increased cortisol and stress reactivity. Overall, it is linked with the aggressive behavior by the latest research by Vanderkopf and Wang in 2017. Um, when it comes to gender, insomnia and aggression, so women are found to be higher on the side of insomnia, whereas men were found to be higher on the side of externalized aggression. But this was never studied in combination with the population in OUD. And it is proposed that gender differences may pose a different or a unique relationship with reference to insomnia and aggression. So, keeping in view the literature review and theoretical background, two aims were proposed to determine if individuals with OUD insomnia exhibit higher aggression level than those without insomnia, and the extent to which gender specific differences do exist in severity of insomnia and aggression. So, with reference to methods, it was a cross sectional survey method, and a secondary data was analyzed from the SORT data. Two instruments were used: Insomnia Severity Index by Martin et al. 2011. Buzz and Perry Aggression Questionnaire was used to tap the aggression. Cutoff scores for insomnia was 10. Any score over 10 was considered as insomnia, and less than 10 was considered as no insomnia. Similarly, with aggression scores, and scores over 75 was considered as a high aggression, and scores lower than 75 was considered as a lower aggression. And these scores were compared. When it comes to sample characteristics, overall, non-pregnant women at least 6 months of postpartum, and men with age range of 23 to 61 years who were stabilized on buprenorphine were the part of study. And in total, 108 participants were present in this study, with majority of women having 60.18%. Overall, the independent variable was insomnia status, and the dependent variable was aggression level that we wanted to study. In demographics, educational status, if you can look at this pie chart, majority 33% of the population were having graduate education diplomas and above. And then high school without diploma was the second, almost equal to those who were below high school. With reference to employment status, majority was unemployed, that was 47%, and a big majority was also found to be on the disability side, that was 19%, and 34% people were employed. With reference to sexual orientation, over 80% of the population reported themselves as straight or heterosexual. Um, in ethnicity, majority of the population was non-Hispanic, and within that, the race was found to be white, that was 58.3%, followed by black, that was 34.3%, and all other races 7.4%. Couples with population having married or with partner was 63%, so majority was living as a couple or single without partner were 37%. Now it comes to results. So the mean score for aggression scores were 21.07%, sorry, 71.66%. Overall, there were no significant differences on the score of aggression in with insomnia or without insomnia group. When it comes to gender differences, there was a significant difference on insomnia severity level. Women scored higher than men, whereas no gender difference was reported on aggression scores. So, keeping in view the results, we concluded that since there was no significant association found between insomnia, aggression, and individuals with opioid use disorder receiving buprenorphine. Future research should examine the role of mediators such as sleep quality, stress, and emotional regulation, insomnia aggression, in finding out the insomnia aggression relationship. And overall, the total sample was also low. So, improving the sample level might also improve the results. Um, s- ki- uh, so by that, I would be concluding my presentation by acknowledging Dr. Kathleen Martin's role and Michelle and Dr. Madison as well. This research was supported by different funding sources. One was the NIDA Invest Fellowship, other included from Michelle, Madison, and Dr. Kathleen's projects. And these are the references. And here we go. Thank you for listening and viewing my presentation. If you have any questions, I'm open to that.
Good job, Rabia. I guess the first question I have is, I know we talked a little bit about this before, but why do you think there was not a difference in the aggression scores by insomnia status in this patient population?
Can you please repeat your question again? Because in the beginning, I lost your voice and then
Oh, no,
I
you're
couldn't.
good. Oh, why do you think you did not see a difference in the aggression scores by insomnia status?
Yes. So there have been multiple mediating variables that we should have, or I should have figured out earlier, because especially when I did research now for the presentation, more research, so I found out subjective sleep quality, which is very much linked with the insomnia. So I've just studied insomnia severity index. With the questions were different when it comes to your subjective perception of sleep. When it comes to subjective perception of sleep. Apart from that, also situational factors do affect the overall aggression level as well. So according to me, if we can study more variables in between which might have played their special role in a mediation, that might have changed the results, or that might have improved the results for future perspective.
And the aggression scores that they did have, it was like 70 something. Is that considered high? I don't know this.
75 and higher is considered as high.
Okay,
Less than 75 is considered as low. So overall cutoffs were under the low side.
okay. But close to high, or 70 something, right?
Yeah.
How does that compare to like other patient populations, like with maybe different mental health things or substance use disorders?
Yes. Personality is one of the important factor, because if someone have already having some personality disorders, especially the one which has mood related, that is bipolar, sorry, borderline personality, because borderline personality is already makes people vulnerable to develop substance use disorder. So
Mhm.
if someone have such, I mean, if we have that population, scores will be totally different. And having someone screened for any presence of mental health or other diagnosed psychiatric condition will also be an important variable in between, because in this population there was no I mean, we screened for diagnosis as well. Those who were not diagnosed with significant like psychosis or something like that, so
Mhm.
it's also was under our inclusion and exclusion criteria.
Yeah, that's a good point. That's kind of what I was thinking of. What I was thinking is, potentially in this data set, if, did we even have enough variation in the aggression outcome to even be able to look at different groups? Or did most of the sample kind of cluster around the 70, 72 that you found? Like, was there even variability is what I'm saying, because we have such a specific patient population and we have the inclusion exclusion criteria, like what you're saying from the parent study. So that's what I'm wondering, is if what the range of scores even was for your outcome. Like, it wasn't even an outcome that we could even look at two groups, not everyone was the same.
Yes. I mean, it also came to my surprise. I mean, I was not expecting this results. I was very hopeful, but that kept me thinking to find more and more reasons. I mean, what could be the main variable behind it, and what I have missed during the designing of this research. Because if we look at the BAPQ score, so it's like 71.66. It's, I mean, it's not very on the very low side. It's like close to the higher side.
Yeah. But clinically, I'm not surprised by that, just based on working in the clinic. So I'm not surprised by the number. But I guess your standard deviation is 20 something. So that's
Yes.
not bad considering the variability. So I
And
was
one
kind
of
of
the
wondering.
reason women, I mean, women who report, I mean, overall majority of the population was women, 61% with, so that might have also cancelled out some results because it's already on the higher side of insomnia. So I'm not really sure that exactly what has contributed to these results with having insignificant difference. Any other thoughts?
I had one. I was just curious, Rabia, if I know you specify gender differences, and I think in one of your diagrams it was a certain amount, like you said, the majority were women, and then less men, and then some, there was a smaller portion that identified as other. I was
Yes.
wondering if like you had any numbers on like their aggression, or if you can remember off the top of your head, like what was that categories yeah, right there. Or no.
Here,
No,
and
it
because
wasn't
this
there.
is
I swear I thought it was like you had some identified as men, women, and then or heterosexual or something like that.
okay.
Like
Then
a
here,
there's a certain amount that identified as straight, heterosexual,
yes. Then this is this
or non-heterosexual. Yeah, for those who identified as non-heterosexual, I wondered what was.
gay, lesbian, and so these were the groups. So we broadly described under because it was the percentage was really low. Majority was on the heterosexual side, so all were grouped together.
Mhm.
Um, yes, in one category it was just one person, and in another category it was probably 3 to 4 people. So that's why we clubbed together while
I see, I see. You
crafting
just
this
close,
presentation. Yes.
you put them all together. I see, that makes sense.
Hmm.
Thank you. Does anybody else have feedback or questions?
I like the framework, Rabia, that you presented. Like, I really like that, and it fits really well with like what the things that we've measured with the phenotyping battery in all of our studies, including this study.
Mm-hmm.
So I do really like that. Um, I know, it was unfortunate we had null
Yeah.
results. I have a feeling it's the sample. I really do. I really have a feeling that's what it is.
Yes.
I mean, you gave great context as to why you thought, the results came out the way that they did, and it's just the limited factors. So,
And I can't remember all the specifics, but like in the qualitative study that we did with SORT,
Mm-hmm.
I
Mm-hmm.
think Michelle can tell me if I'm wrong, but I think people like organically talked about this, about maybe they didn't say the word aggression necessarily, but the participants, when we asked them about like their impacts of their sleep on their lives, on their health, and on their opioid use disorder treatment and recovery,
Mhm.
they talked a lot about how sleep negatively impacted their mood, and their functioning, things like that with their family, etc. So I don't think they use the word aggression specifically. They did use other words like impulsivity,
Yes, yes.
which was kind of great because we
Maybe
measure
it's a
that.
bit harsh word for them to explain themselves, like
Yeah.
because the word aggression comes with explosiveness. So
Mhm.
nobody wants to identify themselves as like being an explosive person. So for example, if the I mean if it would have been captured through some indirect ways, we would have been a better results. Or if there would have been some other scale, or I don't know exactly, but I completely understand the thing you are saying. This is one of the reason, because when you talk with patients, and like actual interviews, then they open up about their thing. But doing
Mhm.
a research survey, people like to have a desirable response. So this becomes a reason usually not to have actual accurate results, and this is one of the biggest limitation of cross sectional study: subjectivity
Mhm.
and response desirability.
Mhm.
Yeah, I definitely think that is something that also contributed to the results. Because, yeah, like Michelle put in the chat, people did mention this in the qualitative irritability. That's what Michelle said. That's what I refer to.
Yes,
Um, yeah, so they definitely talked about it, but it didn't come up in the survey. You're exactly right.
yes. Because when I remember, when we were in our university, and if someone gives us some scale, we try to hide our those sides for which takes us to on extreme levels. We might rate it towards like the medium side, not towards too high or too low.
Hmm.
Maybe.
Yeah, I think one of the learning lessons is the importance of integrating qualitative data into your studies
Yes.
for reasons like this, so you can still capture, the nuances that surveys and validated scales can't get.
Yes. So, Dr. Martin, I have question. If someone is doing secondary data analysis and they don't have the qualitative part in it, what else can be done
For what?
to have to design a good research? For example, if you want to do another research, and you have an access to data which doesn't have the qualitative part, then how we can back up this data or do something with this outcomes?
Yeah, I think thinking about integrating it into a prospective study so you can have more, more rigor in how you look at this going forward, or maybe looking at a different scale, or
Mm-hmm.
asking people questions in a different way about aggression. And so I think we can think about how we can incorporate something that captures this concept
Mm-hmm.
in our future studies.
Mm-hmm.
So, I mean, in our current studies that we have starting, I mean, we are capturing things related to A, B, and C on this slide. Um, with the emotional regulation, the cognition, of course.
Mm-hmm.
And then we're getting, even in our lemborexin study, we are getting like cortisol, et cetera, like biological markers.
Mm-hmm.
So in a prospective way. So I think that is something to do, learning from this cross-sectional perspective that we just didn't capture it with this very homogeneous patient population. But maybe putting in a prospective study, you can look at within person changes and differences rather than between people, and look at that instead of grouping people.
And one thing came to my mind, if you allow me to say. So interestingly, if we look at the um, mean scores of aggression, so within population who were having insomnia, so for a moment, if you forget about if it's significant or insignificant, if you look at the, sorry. scores, participants with insomnia reported 70 and without insomnia reported 72. So it means those who were having insomnia, their aggression scores were lower than those who were having insomnia. That was kind of funny for me. It's in
Yeah,
opposite direction.
yeah, but it's still so close and the standard deviations are the same. I mean, I think it's just showing there's variability, but it's not delineated by the aggression. We found very similar results with some of the other neurofunctional domains by insomnia. So it's not, aggression is not the only one that has come out to not be significantly
Yeah.
different despite, frameworks and prior research.
Yeah.
Gus's prior paper looked at a
Yeah.
lot of these things and we didn't find differences
Yes.
there either.
Yeah. Or maybe since they were stabilized on buprenorphine, they were not like people who were not taking any medications. So
Mhm.
that's why their aggression was under control. Simply, we can put this way as well.
Yeah.
I think that's a very good point, Rabia.
But again, thank you so much, Dr. Martin, for allowing me to complete this study and to have this experience of doing this research. That's very valuable learning for me, and also all those who have contributed to this study. Please
Great job, Rabia.
convey my regards to Dr. Madison and
Mhm.
Michelle as well.
Great. Awesome job, Rabia. Thank you for presenting today.
You're welcome, Dr. Martin.
Anything else, Amber?
Not on my end. Just like I said earlier, anyone who is still interested in volunteering with the lab, just reach out to me and we can get that figured out. Thanks everyone for coming.
Yeah, have a great weekend, everyone.
Thanks, Rabia. See you soon. Bye,
Bye.
everyone.
Bye. Bye.